for joining on the third day on for the Oral Awareness Month, which where ICanCaRe along with the Foundation for Head and Neck Oncology, Sterling Cancer Hospital, and Gujarat University conducting this ICanCaRe second International Oral Cancer e-Conclave. So a very warm welcome to everyone to this third day of scientific session.
Moving forward, the next session is on Maxillofacial Prosthodontic Rehabilitation of Oral Cancer Patient. To chair this session, we have Dr. Shamit Chopra sir, who is Chief in the Department of Head and Neck Surgery at Patel Hospital, Jalandhar. He is also the Executive Committee members of FHNO and Association of Oral and Maxillofacial Surgeons of India. He's been State Secretary for Mission Pink Health Punjab, and he's also been the Chairman of Oncology Committee of Punjab. I welcome you, sir. I also like to welcome the speaker for the session, Dr. Jyotsna Seth, who is Professor in the Department of Prosthodontics and Oral Implantology in Seema Dental College and Hospital. She has done her graduation from Saraswati Dental College and Hospital in Lucknow. She has been trained in palliative care in IAPC course, and she has also been awarded Tobacco Cessation Program Fellowship by ICanCaRe. She has delivered multiple lectures and she has many publications to her name, and she has also been awarded as Best Prosthodontist in the year of 2021. I welcome both of you, and please start the session.
Good evening all, and again it's a pleasure to be associated with this initiative after a fortnight. Without further ado, I think we'll have closing comments and discussion at the end of Jyotsna's talk. Kindly go ahead if Dr. Seth is there.
Yes, sir. Thank you, sir. I thank ICanCaRe Second International Oral Cancer e-Conclave. Greetings from Seema Dental College and Hospital, Rishikesh. To begin with my presentation, gratitude to my guru and my inspiration, due to whom I am here right now. The topic given to me, Maxillofacial Prosthodontic Rehabilitation of Oral Cancer Patient. I would suggest that Srinivasan sir must be understanding my condition right now, because within 10 to 15 minutes, it's very difficult to present that Maxillofacial Prosthodontic Rehabilitation. Still, I will try my level best. Coming to stats of oral cancer in India, a little bit about stats, what we know. The Southeast Asia, they are the most common cancer in males is oral cavity, lungs, esophagus and stomach. In females, the most common site is uterine, cervix, breast and oral cavity. And in the most prevalent form of head and neck cancer in India is oral cancer. And the main two forms, that is the tobacco smoking and use of smokeless tobacco, they are identified as the main risk factor. Now, when we talk about the maxillofacial prosthodontics and its rehabilitation, it's a quite alarming situation that people really actually doesn't know about, that there is some maxillofacial prosthesis still prevailing, because there was one study which was being done and they said that 53.9% of the population only know about the implants and lesser than that know about the maxillofacial prosthesis. It could be due to the low awareness, we can say, the low literacy level or the low socioeconomic status. The other study, it is not only the population, even the medical practitioner were not knowing that which case has to be transferred to the maxillofacial prosthesis, prosthodontics or not. 34.2 people were not knowing as that the prosthodontists are doing such work. And the 10.9% only of the population of the medical practitioner were able to answer the questions of the maxillofacial prosthodontic. So it's a little alarming situation, and I think the need of the hour is right now is the awareness regarding maxillofacial prosthodontic. Coming to the facial appearance, now starting with the maxillofacial prosthodontic, facial appearance affects a person's ability to communicate, and it actually increases the self-esteem and character. And the facial, when we talk about the facial appearance, we believe in facial symmetry. You can see here, nobody likes all these photographs. Why? Because we love facial symmetry, and facial symmetry is all about the facial proportions. Facial proportion is like hairline, the horizontal lines and the vertical lines, all about this. And when there is not a more severely handicapped person than a patient with a gross facial disfigurement, since the most exposed portion of his body is unkindly distorted. And here the picture comes of a maxillofacial prosthodontics. Now, what is actually maxillofacial prosthodontics? Is defined as the branch of the prosthodontics concerned with restoration, replacement or both of stomatogenetic and associated facial structures by artificial substitute. It encompasses the prosthetic rehabilitation of patients with the oral, paraoral or facial defects. And now the replacement of that prosthesis is we call the maxillofacial prosthesis, which is restoring the normal anatomy, the appearance, protects the tissue of a defect and provides great psychological benefit to the patient. Now, why prosthetic rehabilitation? Why not surgery? We have a great session. I was listening to Dr. Mudit sir. They were really excellent sessions regarding plastic reconstruction. But at some times, at few cases, we have to go for the prosthetic restorations. What are those cases? When the recurrence of the tumor is likely, advanced age of the patient, poor health, when the defect tissues are heavily irradiated and the blood supply is very less, and with the large defects. Now, it is not like that the maxillofacial prosthodontics had come into picture right now. No, it was from initially 1950s. You can see the Ambrose Perry and the gunner with the silver mask, a French soldier, and a Kingsley. They also have an artificial appliances. Now, what are the objectives of the maxillofacial processes? Restoration of aesthetic, restoration of function, protection of tissue, therapeutic or healing effect, and the psychological therapy. Now, while talking about the management of MFP, we will say that the personal history of the patient, the dental and the medical intra and external examination of the patient, the psychological and the patient risk assessment, and a surgeon should consult with a dentist or a prosthodontist before to do any surgery. Now, I would not say that it is just an isolated branch. We will say that it's a combination of multidisciplinary approach when we have an oncosurgeon, anesthetist, plastic surgeon, ENT surgeon, oromaxillofacial, radiotherapist, diet counselor, psychotherapist, palliative care also, along with the prosthodontist. And when a little bit about the maxillofacial defects, when we talk about, basically it is being divided into three, that is the congenital, acquired, and development. When we talk about the congenital, we know that it is during the birth. And when the acquired, we talk about it is due to trauma or excision or surgical excision of any tumor or something like that. Or a classification, when we talk about the development, it is due to because of some of the genetic predisposition, like there is a prognathism or retrognathism of the mandible. And when we talk about now classification of maxillofacial prostheses, prostheses is further divided into three majorly: the extraoral, intraoral, and the combination of it. Extraoral, when we are talking about the cranial or the facial replacement; intraoral, which is only involving the oral cavity; and the combination, which is involving the intraoral as well as extraoral. Now, when we talk about the intraoral prostheses, which is further being divided into maxillary, mandibular, tongue prostheses, and the lip prostheses. When we talk about maxillary prostheses, there are a lot other, and then I will explain you later, and extraoral prostheses, which we are not going to deal today, because we are talking about the oral cavity. Combination, we will talk little 2 or 3 slides, because we are dealing with the oral cancer, which is the more when the more thing is being involved. When we talk about the intraoral processes, we majorly talk about the obturative. And then feeding aid processes, about speech aid processes, maxillary ramp, maxillary saliva stimulating processes. In the mandible, we talk about the preservation of the alveolar ridge, mandibulocolectomy processes, mandibular guide flange, and the tongue, the lower augmentation or the upper augmentation. Now, when we talk about the maxillary defects, I told you this is the congenital or acquired. And acquired, we have a traumatic, pathological, post-surgical excision of the tumor. Now, the maxillectomy defects as the classification is being given by Armani in 1978, and they said it is being divided into 6 classification. The first, which is not, it's a unilateral, but not crossing the midline. The second is posterior to the canine. Third is when it is middle of the palate, hard palate, and the fourth, it's a bilateral and crossing the midline. And in class 5, we would say that this is only the posterior side is being involved, and in class 6, we would say the anterior segment. In the maxillofacial defects, the only problem we have, the majorly problem, is the sucking difficulty, nasal regurgitation, dental anomalies, airway problem, aesthetic, speech, and psychological trauma. Now, before surgical treatment planning, we have these team members, including the prosthodontics. Now, surgical enhancement of the defect is also necessary. We want to have a preservation of the hard palate and preservation of the ipsilateral premaxilla. There are few surgical enhancement, because for any prosthesis we need retention, and for retention we need certain anatomical landmarks to get the retention of that prosthesis. So we would like to have the teeth on the surgical side, because the functional fulcrum line then shifts to a more favorable position. When we talk about suggestions to a surgeon, I would like to say that we should have many of the alveolar process and the teeth as possible should preserve without compromising complete removal of the tumor. When we talk about prosthesis, we should not cut along the edges of the bony surface. There should be at least few teeth available to the defected side, so that the fulcrum line to be shifted to the favorable position. And when we talk about the transalveolar interproximal cut, we would suggest that it should not cut between the root, but it should cut between the socket which is being extracted. Now, these are the various indications of the processes, and we have them majorly for the maxillary defect. We use obturator. Obtura is basically closing and opening. So that is what the term comes from, obturator. So it's used to close a congenital or acquired tissue, primarily on hard or soft. Now coming to what are the advantages. This is comfortable, reduce cosmetic deformities, sports upper lip and cheek, restore adequate speech, deglutition and mastication. Now we have three types on the base of treatment, phase of treatment: immediate, transition and the permanent. And material use, this is the metal, resin or silicone. The area of restoration could be a palatal or the meatal. Now when we talk about the immediate, it is just after the surgery from 7 days to 6 weeks. And we can get the retention on the screw, sutures, denture, dental ligature wise and RPD clasp. When we talk about the interim obturator, usually constructed after 7 to 10 days. And when we talk about the definitive obturator, we need to have timing depends upon the size of defect, the progress of healing and the prognosis of the tumor control. A few cases just to make you a little more clear that how these things are being done. So this is the intraoral picture of a patient, which is showing this Armani classification 1 defect. This is the impression which is being taken by the alginate, and the beading boxing of the impression is being taken and the working cast is being made. And for the retentive wires are being made and the wax up is being done. And this is the flasking to be done, and this is record based in situ fabrication of the occlusal rim. While for fabrication of the occlusal rim, we can do the trine in the patient mouth, and then this is the obturator inside the patient mouth. This is the post-operative. These are the pre-operative and the post-operative pictures. Case 2, just a little for the patient complaint of difficulty again in chewing food, swallowing, and difficulty in speech, but a tumor involving right maxillary quadrant. You can see the patient has reduced mouth opening due to the trismus, which we were talking about. Even Dr. Mudit sir has told about this. We can also see that the facial symmetry, there is a gross asymmetry was seen on the right side. Again, this is the primary impression, the cast, and this is the final impression. This is the master cast by the border molding which we have done. Again, the teeth setting and the trine in the patient mouth. This is the final process. This is the bracing arm which is holding actually, and this is the cameo. This is the outer and the inner surface of the denture. And this is the final processes inside the patient mouth. Now this is another case which is showing again the secondary impression of the. There are a few more cases when we are resin bonded attachments. The only problem with the maxillofacial prosthesis is the retention. So whether we should have more teeth which are present in the mouth, we can have a more retention. That is what our main objective is. We can also use a cast partial framework with this so that the retention will be and stability will be improved. This is another, the speech aid prosthesis. There is another huge topic when we are talking about the palatal lift prosthesis, which can be used in the veilopharyngeal incompetency. When we talk about the mandibular, this was all about the maxillary reconstruction. When we talk about the mandibular reconstruction, we know that the defects result from surgical excision of the benign mandibular tumors or oromandibular malignancy. This could be due to trauma or osteoradionecrosis. Now, this was the classification given by, and thanks to this, I would give this credit to Pawan sir because I've forgotten this classification. This was Hcl classification. The H is involving the condyle, L is the lateral segment of the mandible, and C when the anterior segment is being involved. And there are the 8 other combinations which are being used in this classification. Now, the major in the mandible is the mandibular guiding processes, which is actually guiding and realigning the teeth to the occlusion. And the second, the deviation of the mouth is being reduced. This is, you can see the deviation, there is a facial asymmetry, and this mandibular guiding flange helps in aligning the teeth to the occlusion, the normal occlusion, and reduces the deviation of the mandible. There are various mandibular reconstruction with the bony grafts and the implants which are being used, and there is also mandibular lip defects, which is the custom cast retentive elements with the resin bond retainers are being used. Now, a little bit about the extraoral processes, as today is not our topic of the extraoral, but how it is being related to the oral rehabilitation. I would just explain you. There are various types of extraoral processes. We know that upper facial, middle facial, and hemifacial, the nasal, orbital, and the auricular, right? So we know even the causes, the neoplasm, the burns, the congenital deformities, and the trauma, right? Even now these days, the mucormycosis. That we achieve from these processes, we know that aesthetics, the function, the protection, the healing, and the psychological. Now, the major role is the combination processes, where the intraoral as well as extraoral processes both are being combined. You can see here, this is the mid-facial processes. You can see in the picture where the large mid-facial defect is being present. In this, oral processes for the partially dentate patient with a large mid-facial defect. Here, there is an edentulous patient with a large mid-facial defect. So we are giving the intraoral as well as the extraoral processes in the combination syndrome, in the combination maxillofacial processes. This is the orbital exenteration, maxillectomy, and cheek resection defect. This is the nasal processes retained by an RPD obturator processes with the magnates, which is another method of retention. We have a lot of other retentive methods like anatomical, surgical, mechanical. We are using all these to have a better retention, stability, and support of the processes inside the patient mouth. And when you actually realize you didn't mute your Zoom meeting. And now coming to the recent advancement, there are a lot of recent advancement. When Dr. Vani ma'am told about the 3D bioprinting, yes, we are doing CAD remodeling also. The processes designing are also being, there is a virtual try-in also, and rapid prototyping is helping us a lot in the maxillofacial processes. Now, we can see that there are also the maxillofacial implants which are being used. There are auricular, there are nasal, there are orbital, mandibular processes, but the obturator. But today we are specifying on the obturator. We will say there are a lot of advantages. Again, I told you they will improve retention, elimination of the use of adhesive, accurate processes, improved skin hygiene, increased lifespan of the processes, and it also enhanced aesthetics. Now, implant retained obturator, the large defect which is being seen, and the osseointegrated implants are being used. New trends are implants are in use, zygomatic and the craniofacial, and we had quite talked about the zygomatic implants which are being used now these days for the maxillofacial rehabilitation. I think being a prosthodontist, I should say that we are not only just replacing the oral cancer, we have also been a cinematic world. With these words, we can see a lot of Bollywood actors using this, and I will be ending my presentation. So to summarize, I would say that we restore, repair, and make all those parts of the body which nature has given, but which fortune has taken away, not so much that they may delight the eye, but that they may revive the spirit and help the mind of the affected. This is just a photograph of the palliative care. We are at a SEMA Dental College. We are also the palliative consultants. We go to hospice where we give our kind of services to those people. And I think this is the part of us that we should work as a team. And I would say that learning and improvement is lifelong process. Keep learning, keep moving. Thank you.
Great talk, Dr. Jyotsna, and I think I speak on behalf of everyone who attended it that you changed a lot of perspectives with regard to maxillofacial prosthetics. In this age in which most of us as head and neck or reconstructive surgeons end up reconstructing a defect as opposed to rehabilitating it, the issue that arises is that we don't have robust data which actually helps us select the ideal patients for obturation or maxillofacial prosthetic rehabilitation as opposed to flaps. The general rule of thumb, unfortunately, is that patients who are not considered medical or surgical candidates for free flap reconstruction are typically sent to the maxillofacial prosthodontist. I'm glad that you made a very strong point about that not being the case. Of course, extraoral prosthesis, which is outside the topic of this presentation, there is a definite role and a big advantage of prosthetic rehabilitation. Intraoral, I think that we are not only in the phase of combination prosthetics, but I would call it a combination rehabilitation, where reconstructive surgeons like ourselves will do the surgery and then send the patient to you for further optimization. Just 2 days back in our clinic, we were talking about a patient who did a fibular free flap. He had VSP and everything, but despite that, we felt his occlusion is a little off. So our maxillofacial team then sent him for a mandibular guiding flange prosthesis, just like you mentioned in your couple of case vignettes. Just one point and one question I have before any of the other faculty or seniors have any point to make. Maxillectomy defect classifications, you pointed out an Armani classification, which was earlier. From a head and neck surgical standpoint, there are a couple of classifications that are used more often these days. The James Brown classification and the Okai and Erken classification. They are the ones that generally use more. But again, you're absolutely right in mentioning that if you're using one classification, just stick to that. Right. One question I have is that frequently when we do a maxillectomy, the trend, of course, is to preserve as much native dentition as possible, especially the central incisor, even on the ipsilateral side. But sometimes tumor considerations will force us to take the central incisor on the opposite side as well. In that case, your surgical suggestion to us would be what? Should we complete the pre-maxillary excision and give you the canine on which to anchor your prosthesis, or should we leave the lateral incisor on the other side and potentially make it a vascular watershed? It may or may not survive or be vital at the end.
So very pertinent question. So because what happened in we actually want there should be no rotation of the prosthesis. So that is why we are taking central incisor and the second or third molar to the other side, which is being present to the defective side. So we are taking the central incisor to the normal side and the molar from the defected side. So we want these two so that there is we call it a trigonal kind of a quadrilateral kind of a anchorage which we need in the prosthesis. So there is less rotation anterior posteriorly, which will help in retention of the prosthesis.
Okay. The question again, thanks for this. The question pertained to whether we should complete a pre-maxillectomy on the opposite side in case we have to remove the opposite central incisor, or whether we should just leave the lateral incisor intact and not complete a pre-maxillectomy for obliteratory. Just I think breaking it down simply for us head and neck surgeons, just educate us as to what teeth or what classes of teeth are you happiest with in terms of obturator retention. That's my question.
The lateral incisor, sir.
Okay, that's fine. Thank you. Any questions, any comments? I see Dr. Pavan is here, a lot of senior guys, Dr. Prathamesh is here. Any questions or comments?
Just I will ask Dr. Jacob, he wants to say something. Dr. Jacob, please unmute yourself.
Thank you so much. I didn't. I didn't expect to be asked to comment here, but thank you so much for that. Unfortunately, I was not there for the full lecture, but yes, more and more we are doing now free flaps, and my sincere request to all the reconstructive surgeons is please do bone containing free flaps. If you do a lot of soft tissue flaps, it becomes extremely difficult and sometimes almost impossible to rehabilitate these patients. And just like my young learned colleague said, to your question, if it's a lateral that you would like to retain, please don't retain the lateral. Please extract the lateral. What we would like you to actually do is to extract the lateral and make your cut margin through the socket of the lateral so that we get good bone around the canine. The tooth that is adjacent to the defect is of prime importance to us, and either a central or a canine can be kept. If a lateral is going to be kept, then we need to root canal and cut it at the gum line. So, I don't want to take too much time. So thank you very much for acknowledging me here. Thank you.
Point very well taken, Dr. Jacob, sir. We had the same thought philosophy, wanted to drive that point home. You'll be glad to know that most of us in the reconstructive field are beginning to do more and more bone containing free flaps. Of course, mandibular defects were always the purview. Absolutely. But for maxilla, for single segment or single buttress reconstruction, we have multiple options. The radial osteocutaneous, which unfortunately the implantability index is not very high. Right. But in our country, we are trying or striving hard to make sure that we implant those patients. But that's a good single buttress or a pre-maxillary reconstruction that we use. Absolutely. For lateral single buttress, we end up using a fair bit of tip of scapula flaps. Okay. And of course, for a full maxillectomy, our choice would be a fibular osteocutaneous free flap for multi-buttress reconstruction. So, but you'll be glad to know that most centers across the country are beginning to follow that philosophy so that we can rehabilitate these patients. Of course, with your help and expertise. Thank you.
Absolutely. So I understand in the maxilla that getting the vein and the artery is difficult. So wherever possible, we can either rehabilitate them with a bone containing free flap or just do a good skin line defect for us. And as long as we have good teeth, we have some good teeth, we can give a fantastic obturator to the patient.
Great. And there are other vessels that are available though, sir. Dropping it out into the neck is something. But for non-squamous histology with unpredictable nodal patterns of drainage, we are able to hook it up to the superficial temporal artery and vein. So that pedicle is shorter. Of course, we can use vein grafts for the artery as well as the vein.